Sarath, are you there?
Can you hear me?
How are you doing?
I'm good. How are you?
Good.
How is your day today? Busy?
You got your camera on?
Yeah, give me just 1 second, Joe. I'm just trying
Okay.
to wait for this.
Good on.
Joe.
Hey, Takashi,
Hey.
do you want to host?
Yeah, I'm at home.
Okay.
Uh,
You just say hi. I'm Takashi Kon from Japan for Neurosurgical TV.
yeah,
Okay. So you're working for Neurosurgical TV today.
yeah.
Unpaid.
Okay. Thank you. I'm Dr. Kon from Tokyo, Japan.
Oh, not yet. Not
Yeah,
yet. I'll tell,
Neurosurgical TV.
yeah, I'll tell you when. Yeah,
Yeah.
exactly. If you
Okay.
can get the
Yeah, good.
background,
Okay.
fine. If not, don't worry about it. That's fine. Do you want to
Okay.
get the background? Do you want to get the background or no?
Background.
You want the
Get a
background?
background. Okay.
Yeah, you can. You want me to send it to you?
Yeah.
Yeah, let me send you the neurosurgical TV background. Okay.
Mhm.
We got
Okay.
a minute or two of Samath. Okay.
Okay. So yeah, I try to use it.
Yeah, let me get it first. I have a bunch of backgrounds.
Okay.
Hi, Takashi. How are you?
Hi, good evening. Hi, I'm fine. I'm fine. And now, yeah, I'm excited to join. So,
Great.
okay.
Thanks for joining.
Yeah. Script here.
Hold on, trying to get it here. Well, just give me a second.
Hmm.
Okay, I'm gonna send it in the chat here.
Yeah. Okay. This is 420.
Oh, here we go.
Sri Lanka ground rounds.
Okay, here we go. Okay,
Yeah.
I put it in the
Okay.
chat.
Okay.
You
Okay.
see it? You see it, right?
Yeah, I can download.
Yeah, download it and then you go to the video and upload the file.
Okay. Okay. This is the Miami Beach.
Right,
Okay.
Neurosurgical TV.
Okay.
It's a big day for him, Sarath. He's
Hmm.
It's after a
taking
long time, isn't it?
Yeah, he's worked a long time. He's earned it.
Okay. So I try to my background. So the virtual background. So I try to
Yeah, you go to
use
the
use.
video menu. You
Okay.
go to the video menu, choose virtual background.
Virtual background. Okay.
Yeah, and then check the plus mark and look for it on your
Okay.
computer.
Okay. Oh, this one.
There you go. There you go.
Here we go.
Okay.
Okay. Yeah.
We're,
Okay.
we're, we're ready
Yeah,
to
from
go.
Miami.
I'll count you down after I go 5, 4, 3, 2, 1. Then you say, hi, I'm Takashi Khan from
Yeah.
Neurosurgical TV.
TV in Tokyo,
Okay.
Japan. Okay, so the title is today's title is okay. I want to let them
Oh,
know.
no, just briefly introduce Sarath. Okay,
Ah,
he's a
okay,
neurosurgeon from Sri Lanka. He's done a lot of these webcasts. He's done them regularly.
regularly. Okay, case history. This is a
And
case history, and the presenter will be so you can
he's presenting. Sarath is presenting.
okay, okay. So that's
Okay.
menacing.
Yeah,
Okay,
you can read that too. Just like a conference. Just like a
just like
conference.
converse. Okay,
Yeah. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, go.
okay. Good evening, ladies and gentlemen. I'm Dr. Takashi Kon from Tokyo, Japan, from Neurosurgical TV. Today is the Sri Lanka Grand Rounds and very interesting case history. Dr. Suras, please. So, Suras will present. Dr. Suras, please, chair.
Yeah. Thank you, Takashi, for the introduction. Good afternoon, good evening, good morning, wherever you are. And good afternoon, John from Sri Lanka. Thank you very much for the opportunity. So we have been together for the last 5 years. I can remember the first Neurosurgery TV webinar we did in 2020. So it has been almost 5 years. So it's been a great pleasure to collaborate with you. So today, another Sri Lankan brand round. So I thought of discussing a few interesting cases, as well as mainly a recap of what I have done, what I have been doing for the last 45 years in my center. So first of all, let's share my screen. show my, can you see my screen?
It's not big screen.
Yeah.
It's not presentation mode yet.
Right. What about now?
Perfect.
Perfect.
Yeah.
Okay.
Okay. So, give me 1 second. So it's going to be a interesting case presentation. So conquering complexity through simplicity. So this is where I work. This is the Sabaragamu province. And in Sabaragamu province, we have one neurosurgical center, a tertiary center, teaching hospital Ratnapura. So this is where I work. So this is the whole Sabaragamu province. And I have been the solo neurosurgeon for the last 4.5 years there. So all these cases I'm presenting to you being operated at Ratnapura Teaching Hospital, and all these patients are from the Sabaragamu province. So for the last 4.5 years, so we have been doing a lot. So as I always mention, and I have always been talking about operating under difficult circumstances. So whatever the circumstances, we know wherever you work, wherever we operate, maybe from America, maybe from Europe, maybe from Africa, Sri Lanka, wherever it is, what we expect is a safe surgeon and a good and a safe outcome for the patient, for your patient. So what matters most is the outcome and operating with the proper technique. So I think one of the most important aspects for a neurosurgeon is to be a safe surgeon. So that's what I always uh, talk about when before I discuss my cases. So always we need to know your anatomy, adhere to the principles. Accurate decision making is very important for a neurosurgeon, especially when working under difficult circumstances and when working under restricted settings. So the accurate decision making comes with your knowledge, with your skill, and with your thinking pattern, with your attitude, and with your experience as well. So it is a must. It is a very important aspect for a neurosurgeon when working under difficult circumstances. And also, you need to know, anticipate, properly manage your complications. If you get a complication, if you can't manage that, I think it's better not to do that type of cases. So always perform safe surgery towards the best outcome. So it's very simple. So in a nutshell, the vision is patient safety and the best long-term outcome. So in that case, sometimes when you are working under difficult circumstances, you have to utilize your whatever the available resources at the maximum. And also innovate when it's feasible. So the mission is performing the surgery to achieve the best outcome for the individual patient, utilizing the available resources at the most appropriate time for the most simplistic and uncomplicated procedure. So it is not always regarding the most sophisticated procedures, the most sophisticated techniques. It could be the basic microsurgical technique you perform. And it may be the most simplistic and uncomplicated procedure which gives you the best outcome. So this is another slide which I always put on when talking about these kind of topics. So if you want to change, if you want to do something, you should have all these things. You should have a vision, you should have skills, you should have incentives, and you should have resources and an action plan. So if you don't have the resources, sometimes you end up in frustration. So that is why we need to innovate sometimes. We need to look for innovation and we need to look for alternatives which will prevent frustration. So this is what we do most of the times. So not only for me, now we have talked about global neurosurgery all over the world. So we have seen this is a common problem for most of the neurosurgeons in some part of the world. So, I mean, ICUs, HDUs, I mean, resources, manpower, public misbelief, the ignorance, and all these are sometimes we think as drawbacks. But I think these are the real challenges. So we need to think them as challenges which we need to overcome rather than drawbacks. So to bridge that gap, so sometimes we have seen there is a little bit of a defect in the technological advancement. So in that case, we can bridge that gap with thorough knowledge. If you know your anatomy and function well, and if you are a skilled and a safe surgeon with a sound composure, and you need to have the correct attitude, so you can look for safe and effective alternatives or innovations without violating the principles. So you can bridge that gap most of the time. So you can achieve uh, at least 90% of what you could have achieved with the most sophisticated technological advancements in terms of the patient outcome. Right. So this is just an introduction, but I always like to start with when I start a presentation uh, on a topic like this. So for the past few years, these open minimal access approaches have worked very handy for me in these types of situations, like hypertensive ICH, even in gliomas, meningiomas, and AVM. So I'll show you a few cases where I have uh, operated with this open minimal access approaches. So I think I have done a presentation previously on hypertensive ICH as well. So I will just try to give you a very brief flashback on this. So because I would like to talk on this topic in detail in near future in a different presentation. So hypertensive ICH, as you all know, it's one of the most common killers. Uh, and it's one of the very common killers in our setup with more than 50% mortality. That is uh, various due to various factors. So most of the time, it's because of lack of the proper management, proper facilities such as ICU and HDU, and also some these patients being mismanaged most of the time at medical units because they present directly to the medical units rather than to the neurosurgical units because of uh, restricted resources. And also, the anesthetic staff and the theater facilities are restricted sometimes. So I was looking, I was trying to uh, find out, or I would rather say innovate, a technique which I could evacuate these deep intracerebral hemorrhages through a mini craniotomy, even under local anesthesia or sedation, because most of the times general anesthesia was not possible due to the above mentioned facts. So basically, I was looking for a safe and cost-effective and also quick method with good neurological outcome. So this is how our patients suffer from the complications of this hypertensive ICH. Most of the time, they get aspiration pneumonia, and even though we perform tracheostomy, so they succumb to respiratory complications. So these are the hypertensive ICH we talk about, but this is not what I'm talking about. This is this is craniotomy and evacuation of ICH. This is not what I'm talking about. What I'm talking about is a mini craniotomy. A mini craniotomy is just slightly an opening, slightly larger than the burr hole. So you can see here, this is the size of the opening usually that I make. So you can do this even with local anesthesia or sedation. But there are difficulties, there are restrictions when you're operating under local anesthesia or sedation. It's not possible always. You have to think, you have to understand that. And ideal to do it under general anesthesia, but there have been so many times that we were unable to operate with general anesthesia because of the lack of anesthetic staff, sometimes especially at night. So this is one example of a patient with a large hypertensive intracerebral hematoma evacuated through this small opening. So usually this is through the temporal approach, and sometimes you can do it through the frontal approach as well. So this is the scar. So this is when I started doing the evacuation, maybe 4 years back. But nowadays, the incision is very smaller than this. So this is this patient after 3 months follow-up. So another case, you can see the opening, the craniotomy is small. Again, this is the immediate post-op. These cases were done under general anesthesia, and this is uh, at discharge, the CT at discharge, and this is the patient of 3 months follow-up. Another case, similar cases. So again, the temporal to the temporal minicraniotomy to temporal approach. So you can see all these CTs are on post-op day one, and this is on discharge. You can see the hematoma is almost resolved with the associated edema. So there is no, I mean, some people would say, what about the edema? If you do it with a small opening, so you can see the edema is almost settled even at the end of day 10. Another case, so this is the recent one. So I have been doing evacuating these hematomas to the frontal burr hole as well since the last 2 years. So going to the frontal burr hole is not that easy. So you can see the pathway from the starting point to the hematoma is long, but a near complete evacuation can be done because of the leverage, the increased leverage. And so I'll talk about this in a different presentation. So I just want to show you. This is one of the techniques which I have used, and all these patients went home even with the disability. So this is another case, 43-year-old female, again with a large hematoma. So again, this was done to the frontal approach. You can see this opening is very small. It's a very small craniotomy, just a few millimeters, or I would say, yeah, few millimeters larger than a burr hole. So again, you can see this is the outcome. So you can see to the frontal approach, the near total evacuation of the hematoma can be done. But actually, you don't need to evacuate 100% of the hematoma. Even 85 to 90% of the evacuation is sufficient to get rid of the secondary the pathology and the secondary complications due to the hematoma. Another case, you can see a large ICH, a dominant hemisphere, again done through a small burr hole. So you can see this is the CT on the post of day one. So this patient had undergone a chronic SDH evacuation before. So I went through the same frontal burr hole. So you can see this is where I started with my entry point, done the evacuation. So this patient, to our surprise, improved a lot, and he's almost GCS 10 out of 10 with the tracheostomy, and he went home on day 18, first operatively. So not only ICH, so I have done evacuation of IVH as well. So this is a example of IVH evacuation. To the parietal burr hole, and I have put inserted an EVD. So it's not only IV, ICH, we can do IVH evacuation as well. So this is my experience. I just want to show this. So by end of December 2023, so I had done around 3 cases for the last 5 years. So the 30-day mortality, so around 12.5, which is remarkably low compared to the previous mortality. And the 6 months mortality is 16%. So the number of patients with favorable modified ranking scale is around 60% at 6 months, according to the retrospective study. So that is one way of overcoming a really a big problem, a real big problem for us. Because we get a lot of intracerebral hemorrhages, a lot of high frequency ICHs in my area. So we usually get around at least 1 or 2 cases per day. So it comes around 30 to 40 cases per month, and out of that, around 10 cases, 10 patients undergo surgery. And another scenario, this is another scenario. So thick subarachnoid hemorrhage. Patients, especially elderly people, presenting with thick subarachnoid hemorrhage with a low GCS. So these type of patients at our setup, we have seen they deteriorate very quickly because of the cerebral edema and the other pathology. So even before we perform the CT angiogram, these patients deteriorate and most of the time they die. So what I do in these situations, the problem is that we are unable to provide the ideal care for them because of lack of ICU facilities. So most of the time, these patients being treated in the wards, even not in the HDUs, so their condition deteriorates. So what I do is we do dominant hemisphere decompressive craniectomy for these patients. So this is one case example. So this is after decompressive craniectomy, and then we do the CT angiogram, and then we do the aneurysm clipping. So this is another scenario like this. This is done recently. So a dominant hemisphere decompressive craniectomy. This is after 48 hours, the CT, and this is after 5 days. So you can see this patient's interesting case. This patient's CT angiogram came as no aneurysm seen. But if you see the first CT, this is very full-blown thick subarachnoid hemorrhage. It's very unlikely that there is no aneurysm in this patient. Because this is not uncommon in my setup because the CT machine is a very cheap 60-CT machine. So it's very difficult when there is a lot of blood. It's very difficult to identify even for the radiologist to pick up the aneurysm. So this is a not uncommon scenario. So we were planning to send this patient for a DSA, transfer this patient to a different hospital, but unfortunately this patient deteriorated. So I decided to operate because I had the gut feeling that this patient was having an aneurysm. So I'll just show you the video of this case. So looking at the CT, I thought it would be an aneurysm, either an MCA or ICA of on the left side. So so this is an unedited video. So I'll just skip through some of the steps. Editing of the video takes a lot of time, as you know. So I'll just show you the glimpse of aneurysm. So there was an aneurysm. You can see this is the internal carotid artery. So this was the aneurysm. It was a big ICA aneurysm, as I thought. And the clipping was done. So started rupturing soon as the clip was applied. So the patient survived. And so this is not the first time that I had to operate without a proper CT angiogram because the patients, most of the times, they deteriorate. By this method, by doing a decompressive craniectomy for these type of patients, we have been able to save maybe around 10, 12 patients for the last 6 months. Yeah, 6 months to 1 year. Right. So another scenario, scenario number 3, adapting to the situation with minimal access approaches, as I said earlier, and also under local anesthesia or sedation. So this is, which I'm going to show you, is resection of glioma under local anesthesia. It's under complete local anesthesia, or what we call a scalp block. So there is a set of patients in my country, or I'd rather say in my area. They have a fear of general anesthesia. So they are very reluctant to undergo general anesthesia. They are not reluctant to undergo surgery, but they are reluctant to undergo general anesthesia, mainly because uh, they think that after GA, they might not recover, or because of the fear of complications, such as they will wake up with a weak or a paralyzed limb, a paralyzed side, or they might not recover, they might not wake up again. So we had a group of patients, around 8, 9 patients for the last 6 months, because of some reasons which happened, which took place in the recent past as well, with some anesthetic drugs in my country. So, and also there were patients with comorbidities who had high risk of a GA. So these type of patients I selected, and I operated under complete local anesthesia, complete scalp block from skin to skin. So this is one of the cases, one of those cases, patient with a glioma in the dominant hemisphere. So in the Lachlan region. So I thought of operating this patient under local anesthesia. It's like a big surgery, but only the intention or the indication was different. So this is the immediate post of MRI on after 48 hours. So you can see the complete resection of the glioma has been done. And this is the CT, so you can see this is the incision. So this was done completely under local anesthesia, under scalp block. A good scalp block was given by the anesthetist. So in the interest of time, I'm not. This is a fast-forwarded video. So we have been communicating throughout, uh, throughout the procedure with the patient. And so I'll skip in the interest of time. And this is a similar case, another patient with right temporal glioma. And again, these are the preoperative images. This is the postoperative images. This is the postoperative MRI. Again, complete resection has been done. So these are some intraoperative images. So patient was buttoning his shirt back just after the surgery, and this is post-op. Another case is a young lady with a primary breast CA and a secondary on the dominant side. And she had the fear of losing her speech following surgery, so we decided to operate under local anesthesia. So these are the preoperative images. And this is the immediate post-op contrast. You can see a complete resection of the tumor being done. And these are some intraoperative. So we have been talking with the patient all the way throughout the surgery. So it's like a vitrectomy. And for the interest of time, I will skip the video. So this is post-op. So her speech is preserved. And after 6 months, there was no recurrence. Another case, another posterior parietal lesion in an old patient. So the family members had the fear of death following GA, not the patient. So again, we did this patient under local anesthesia. So you can see complete excision of the lesion was done, and this is the post-op. No any neurological defect. Another case, 54 years male with primary lung CA. You can see his chest X-ray. You can see primary lung lesion. So the anesthetist was not very happy to proceed with general anesthesia for this patient because of the anticipated respiratory complications. So we operated under local anesthesia from skin to skin again. So again, this is intraoperative the video that we are operating with the communication with the patient, and this is so this is just after the surgery. So he can read, he can see, he can talk. Right. So some interesting patients. So there are lots of interesting patients, lots of interesting beliefs, conceptions when you work in this part of the world. So their beliefs are different. So we have to be flexible sometimes. So I think you need to take the opportunity and innovate or look for alternatives in these type of situations. And yeah, this is another case. This is a patient with polycystic kidney disease and refractory epilepsy because of this vascular malformation. And patient renal functions poor. So I did this. I resected this AVM under sedation. So my intention was to operate as soon as possible, quickly as possible, with minimal uh, with minimal access. So the morbidity for the patient is low. So what the problem I had was doing minimal access with a limited incision. So to look for this, you can see this sulcus, to identify this sulcus without a navigator, because I don't have a navigator facilities, but skill. So this is the sulcus I was looking for, but still I was able to locate that with the anatomical localization with the markings of the CT, and just see with this video how we proceeded. So you can see it's a very small incision. It's a mini craniotomy temporal region. This is the sulcus I was talking about, and this is the lesion. The lesion was completely taken out. This is the post-op image. This is the pre-op. You can see even with the CT, he had multiple hemorrhages, multiple episodes of bleeding. And this is the post-op. You can see it's a very small craniotomy. It's a mini craniotomy and a very small incision. You can see this is the incision, and this is the drain. And he was sent home on post-operative day 3 without any problem. This is just to show you. We have been removing brachial plexus tumors. This is another patient who was reluctant to undergo general anesthesia. So this case was done under sedation. These cases under sedation. And this was taken out. So this patient had C7, C8 pain along the C7, C8 distribution, and the weakness in C8T1. So this is post-op. The weakness completely improved, and she was a very happy customer. Talking about minimal surgery. So I told you I use this technique for patients with severe comorbidities. Patients who have severe comorbidities and high risk for GA. So the intention behind the technique is minimal morbidity and to as quickly as possible without any collateral damage. So these are few scenarios. These meningiomas done with a mini craniotomy and a very small incision. So, I mean, you don't always need technology. So if you know your anatomy and if you can localize, so you don't need even a navigator for these type of lesions. So you can see it was done with the mini craniotomy and the complete lesion was taken out. A similar case, again, a patient with ischemic heart disease and hypertension. So again, operated with a very small craniotomy and the meningioma was taken out. Another case, similar case, a large meningioma. So we made the opening, which was sufficient to take out the meningioma. Through a straight incision, this was done. And luckily, it was a soft tumor, not a very firm tumor. So this is after taking out the meningioma completely. And this is, unfortunately, I don't have a post-op CT of this patient. And this is done on the same day as the second case, another large meningioma. But in contrast, this tumor was very, very firm. So it was very difficult to take out the tumor with just with even the micro scissors. So we had to use the fine scissors, the med-central scissors to take out the tumor. So I'm sure you all know how hard it is when you don't have a CUSA sometimes, like soft tissue debrider. So operating these calcified and firm to hard meningiomas is quite a task, which needs a lot of patience. Just to show you the contrasting surgeries on a same day. Right, another scenario. So these are not uncommon situations or circumstances in my area. So operating tumors without a preoperative MRI. So this is a case of a large tumor presented to us a few years back. So the tumor was a moderate in size. So we asked the patient to get an MRI done, but we planned the MRI, but the patient defaulted. So she went home saying that she is not willing for surgery and went for native treatment, went for probably Ayurvedic treatment. And then she came to the hospital after 8 to 9 months with a GCS of 3 and the CT showed this. So this is not an uncommon situation in my area. So patients with large tumors, mainly because they neglect their symptoms or they go for native treatment, they end up in getting their tumors at a very large size and they present to hospital at the last moment with low GCS. So this is a similar situation, this patient with a large olfactory groove meningioma. So at that time, we did not have MRI facilities in my hospital. We did not have an MRI machine. So this was operated with the contrast CT. So it's not an uncommon situation for me. Another similar situation, similar case, olfactory groove meningioma, large one. So again, that time MRI was not available. So the patient was not in a good shape to send for MRI to a different hospital. So I operated with only the CT. So when you're operating under these type of situations, so the most important thing is that you need to anticipate, you need to think about all the possibilities, all the important structures, and you have to be patient and you have to be more precautious because you don't know what you're going to encounter, but you have been in this similar situation before. So you know what to expect. So if you know what to expect, you can be extra precautious and it's not impossible to operate without an MRI. So this is 2 years follow-up and she had no recurrence. Another case, large meningioma, you can see this is post-op. Young patients, they neglect the symptoms and they present with large tumors, right? So another case with a large meningioma, sphenoid wing meningioma. This is non-contrast. You can see the tumor even with the non-contrast. It's a calcified tumor. This is contrast, and this is immediate post-op. So all these patients had a very good outcome. They did not have any post-operative neurological deficit. This is a patient with the posterior fossa meningioma presenting with the GCS of 4. You can see the tumor. It's a calcified tumor, but probably a meningioma. So we had no time, even though we had MRI facilities at that time, even contrast CT was not done because the patient was deteriorating at that time. So we inserted an AVD test, but I thought of going for the resection straight away, considering the situation. So we operated with just this CT, this non-contrast CT. So it was a meningioma, and the near total excision was done, and she survived. Another patient presenting with this left frontal meningioma. Again, this is a contrast CT. She presented with low GCS, a GCS of 7, and we did the complete resection, and she survived. Another case, a posterior fossa meningioma, presenting with low GCS. Again, the excision was done. So similarly, I can show you so many cases. So these are not very uncommon in this area. So this is a cavernous sinus meningioma. So this was done 5 years back. So this is the only image I had for this patient. And you can see, even I don't have the post-op imaging, so I have the clinical evidence. So this is pre-op, this is immediate post-op, and this is after 2 years. So this was done actually when I was in Eastern Province. So this photo was sent by the medical officer there because I shifted my working station from Katiklo to Ratnapura. And then this patient presented after 3 years of the initial surgery. Another case, a hemangiopericystoma. Again, this is a non-contrast CT. This patient presented with, you can see the posterior fossa crowding, presented with a GCS of 5. So I had to operate immediately. So this was operated, and these are some intraoperative pictures. It was a hemangiopericystoma with a lot of bleeding. So this patient survived. So many patients survived. We have saved so many patients' lives. It's true that the conditions, the preparation, the preoperative imaging was not optimal, but it's not always the preoperative technique, technology, and preoperative optimization. Sometimes you have to think about patient's outcome. So these type of situations have been very frequent. So scenario number 5, cystonostomy. So for the last 5 years, we have been practicing cystonostomy in my center. So for subdural hematoma, nowadays we prefer cystonostomy. Sometimes decompressive craniectomy, and for patients with if there are indications, ideal indications for cystonostomy, we prefer cystonostomy rather than decompressive craniectomy. And this is actually the inspiration for me to perform cystonostomy. So this is the first case I performed cystonostomy, which is 4 years back. A young lady, an 18-year-old lady, who presented with this thin SDH, but with severe cerebral edema, with a GCS of 3. So I decided to do a evacuation of subdural hematoma plus cystonostomy. You can see the drain, the EVD is in the preponderant cistern. So this is the CT after 48 hours. And these are some intraoperative images. And you can see, I thought, I expected a very poor recovery for this patient. So we did the tracheostomy at the same time, at the same go, because we have a limited ICU capacity in my hospital. So we have 70 consultants in my hospital, 70 specialists, but only 17 ICU beds for the whole hospital. So from a neurosurgical point of view, so it's very difficult to get more than 2, 3 ICU beds at a time. And we preserve the bone flap in the abdomen. I think I have showed this case before, and I have presented before, and we did the feeding tracheostomy as well, because we expected a prolonged recovery for this patient. Yeah. But then I thought whether it was an overkill for this patient, but it paid off very, very well for this patient. So this patient recovered very remarkably, and on the day 24, we were able to replace the bone flap and do a cranioplasty and send this patient home by the end of day 28. So it was the inspiration for me to perform cystostomies. So we have done so many cystostomies, more than 200 for the last 4 years, 5 years. So these are examples where that we have put the bone flap back. In some situations, we have not been able to replace the bone flap. So the biggest advantage for us is the marked reduction in the number of cranioplasties, because we have problems in preserving the bone flap in refrigerators. So what we usually do, we preserve the bone flap in the abdominal sac. But that also was not very promising, because some patients, once we discharge and when we give a date for them to come back for cranioplasties, they never turned up. And they turn up, they come back in 7, 8 months, even sometimes after 1 year, when the bone flap is being resolved. So most of the times we have been depending on titanium cranioplasties, titanium mesh, which is very expensive. So a 20 centimeter by 20 centimeter titanium mesh costs around, with the screws, 200,000 Sri Lankan rupees, which is very expensive. So the average monthly income of a average Sri Lankan laborer is around, say, 50,000. So 200,000 is, they cannot tolerate that. So from an economic point of view, the number of reduction in the cranioplasties has been very cost effective for us. It's 27% for considering all the cases we have done over the last 4 years. Right. So that is another strategy that I used over the last few years to get a better outcome, as well as to get an economically effective or cost-effective outcome in trauma, brain trauma. Another scenario, using fibula as a graft material. So most of the time, we did not have corpectomy cages in my center. So I had to use fibula as a graft material. So I prefer fibula rather than the iliac crest, and it has worked very well. So there are so many evidence, so many articles regarding the effectiveness, the efficacy of fibula as a graft material. So you can see around 40-50 cases. So it is an excellent graft. It fuses very nicely. You can see after some time, the fusion rate is very, very good. So believe me, it's a very, very good alternative if you don't have the accessories or the consumables at your unit. And also, another scenario, replace the technology with the clinical acumen. So C1, C2 fixations, some people use the navigator, yeah, it's better to use the technology always, right? If you have the facility, but if you don't have the facility, you can replace it with a good clinical acumen. So all these cases we have been doing without the navigator. Uh, Actually, you don't need a navigator, according to my belief. But we all work towards the patient's safety and a good outcome. So there is no harm in using the technology if you have it. If you don't have it, then you don't have it. So use your clinical acumen. So these are few cases just to show you. This is a 91-year-old male patient with a C1, C2 fixation. So again, few cases, again, thoracic fixations. I'll just skip this. And this is an interesting case. I just would like to discuss. This is a patient with neuric grade 6. He was bedbound. You can see a severe stenosis, canal stenosis, severe cervical cord compression. So this patient presented to me 4 years back. So this is what I could provide him at that time. So we had the ACDF cases, so I did a 4-level ACDF. So I did not have these anterior cervical plates. So even though I would have definitely put a plate if I had, but just did the ACDF, and this is 2022. After 1 year, he was walking. He had the incontinence, the bladder bowel issues, although it is acceptable considering his situation. So he was walking in 2022, and then in 2023. So the lateral mass screws were available at my in my hospital. So I got him back and did the posterior fixation and did a posterior decompression as well. And then his symptoms improved markedly. And this is in 2024. So he was walking without support, and the catheter was removed, and it was I mean, very good improvement and marked improvement. And it was a very rewarding experience, because we have been following this patient all the way through, and all the way through it was only an improvement. Right. Another scenario, junctional tumors. So junctional tumors, once you remove the tumor, there is this controversy whether to fix, whether to go for an instrumental fusion or not. So most of the times, rather than an instrumental fusion, we prefer laminoplasty for this type of situation. So this is one case, one scenario where we removed the tumor and we did the laminoplasty for this patient. So you can see this is the pre-op. So this is the post-op. So we do the laminoplasty, and this is preoperative neurology of the patient. So this is the post-operative. So this is post-op day 2. Right. So another case, a young female patient with a large intramedullary tumor, a lipoma. Again, we did the junction. So rather than going for fusion, we did the laminoplasty for this patient. So this is the post-op CT, where the laminoplasty being done. And so you can save your consumables if you don't have it freely by these type of strategies, which works very well. Just to show you a few cases, complicated cases, because it is a recurrent posterior fossa meningioma in a 75-year-old male patient with sinus involvement, with involvement of the sigmoid sinus. So this patient presented initially to a different hospital, and he was told that surgery is very risky and is inoperable, and he came to us. And unfortunately, the patient's condition was deteriorating, so the patient was willing to undergo surgery. And this is the preoperative axils and the surgical MRI images. So this is the intraoperative image. You can see the tumor has eroded through the previous defect, the bone defect in the posterior fossa. And these are some intraoperative images. I have the video, but unfortunately, it's a long video. I have no time to edit. So these are few of the pictures. So this is after the complete resection, and the sinus was reconstructed. And these are the immediate post-op images. 95% of the tumor was taken out. So these are the post-op MRIs. So this is pre-op and this is post-op. So this is the post-operative image of the patient. And he had no cranial pulses. We did the tracheostomy because we had issues with the as I said, with the prolonged ICU care, and patient had aspiration pneumonia preoperatively, so we did the tracheostomy for this patient. So another case, a young patient with a recurrent WHO grade 4 glioma in the dominant hemisphere. This patient again was operated in different hospitals, first time initially, and then presented with the recurrence. And then again, he was told that it is inoperable and it's risky, and he would end up with the right-sided weakness and with aphasia. So again, he presented to me, and I operated him. So when operating these type of tumors, so they're allowed to have the navigators and intraoperative neuromonitoring and Glaulan, but unfortunately, in my setup, I don't have any of these facilities, but still, this is pre-op. So this is post-op after 6 months. So this patient has no recurrence. I don't have the immediate post-op, the CT or the MRI, but this is 6 months post-op. So no recurrence, so no residual tumor. And yeah, this is the post-op MRI. So this is him, only a mild dysphasia. He has no post-operative motor deficit, and only a very mild dysphasia at 6 months. So it's achievable, still achievable. This type of operations can still be achievable, even with your basic microsurgical techniques and with your basic whatever your armamentarium. Another case, a recurrent medial sphenoid wing meningioma. An old lady, 70-year-old lady with recurrent medial sphenoid wing meningioma. Again, she presented to me, and because she presented to a different hospital, and she was told that the operation of this tumor is very risky and life-threatening. So it was a very difficult tumor. All the major vessels, the internal carotid, it is cerebral, even the anterior cerebral, was engulfed by the tumor, and it was a very firm tumor. So you can see this is the tumor, the preoperative CT scan, and this is the post-op scan, and you can see a sliver of tumor being left in situ, which was firmly attached to middle cerebral artery. So it's always, we need to think about patient safety. So rather than trying to be a hero, so under difficult circumstances, it's always better to leave a little bit of humor, and rather than going for a complete resection under difficult circumstances, because you need to know about your limitations and what you can achieve and what you cannot achieve. Right. Similar case, a similar tumor, medial sphenoid ring meningioma with encasement of all the blood vessels. But this was done recently, three weeks back. These are the preoperative images going through the cavernous sinus as well. But this was amenable to resection because the tumor was not very firm. So this is the post-op contrast CT. So complete tumor excision was achieved. This was after 48 hours and a little bit of subgaleal blood. And this is on discharge after 14 days. This is the post-op CT at discharge, on discharge after 14 days. And this is her. She had no weakness, no neurological deficit. So if it is amenable to resection and you are confident what you can achieve, what you're capable of, then I think you need to go for the best. But if you don't, then it's better to go for the safest option rather than trying to go for the complete resection. This is an interesting case which I operated a few weeks back. So this is a 77-year-old female presented with refractory epilepsy and severe headache. So she was getting continuous fits in the ward and she was having very, very severe headache. And this is the non-contrast CT she presented with. And unfortunately, the renal functions were not that good and we could not go for a contrast MRI. So we thought it's not safe to inject gadolinium to this old lady. So this is you can see it's a calcified lesion. So you can see the tumor in the non-contrast CT. So again, I thought of going for a minimally invasive or minimal access approach to get rid of the tumor. But what caught my eye was this hypodensity. But on questioning during history taking, the family members or the patient herself had no clue of what happened before. The only thing she told me that she went to the hospital after attack of loss of consciousness and a seizure, and she was hospitalized for a few weeks, and they offered the hospital, the doctors offered surgery, but she denied. So most probably I thought this could have been a bleeding into the tumor. So she was offered surgery, but she denied. So this is what I encountered of the tumor resection. So there was an aneurysm. There was an anterior communicating artery aneurysm in this patient. So I'll just show you the video, unedited video of this patient as well. I will just quickly go through it. So you can see this case was done through the eyebrow approach, the supraorbital approach, because I was planning for a minimal access resection for this patient. So you can see the tumor is eroded, has come out. And you can see it's calcified, so it was firm to hard. So the initial devascularization was done, and then debulking. So it's a calcified tumor, so the resection was not that easy. I had the CUSA, but CUSA was of not a significant value this day. So I'll just skip this and I'll go to the end. Right. So I'll just show you the pictures. So this is at the end of the tumor resection. This is what I found. It was an aneurysm, and that was the first glimpse of the aneurysm. So after dissection, so I realized that's anterior communicating artery aneurysm, and the aneurysm was clipped. And this is the post-op CT. So the complete resection was done with the aneurysm clipping. So it was bleeding into the it's an aneurysm rupture with the meningioma. So this is the post-op image. So this is on discharge. So you can see this is at the follow-up at the suture removal on day 14. So it was done through this supraorbital eyebrow approach. So it's an interesting case. Right. So this is another case. You can see large tumors, non-contrast CT, a posterior fossa tumor. Patient was bedbound due to unsteadiness for 2 years. Again, a 68 years old lady with this huge tumor. She has severe headache and unsteadiness. Then she was bedbound for the last 2 years because of the symptoms, unfortunately. So these are some unfortunate scenarios in this part of the world. So this patient presented with the hydrocephalus, so we inserted an EVD first, and then again this patient had renal impairment, so MRI was not possible. And sometimes we don't wait for MRI because it takes time. So we don't, rather than wasting time, we operate with the contrast CT, depending on the circumstance. So this is the preoperative the image. You can see it's a large tumor. Again, the same principles. And this is the immediate post-op. The contrast CT, the complete tumor excision was done without any neurological deficit. Just agitated. So this is the patient. So you can see the patient is cachectic, wasted, because she has not been properly been treated for the last 2 years. So her lower limb weakness slightly improved after the surgery, but her symptoms, she had a 90% improvement of the symptoms after the tumor removal. So I think the job done. The last case for the day, you can see this young patient presented to us with this complete fracture dislocation at L3-4. So you can see at L3-4, it's a complete aortic 4 injury. So this patient is working as his job is climbing the what you call the skittle trees, and he had a fall from a 60 to 70 feet height, and this is what he ended up with. So this is MRI, and you can see severe damage to the nerve roots. So this is the just before the surgery. So you can see his power of left lower limb is 1 out of 5, right lower limb power 0, but he has sensation intact. So this is some intraoperative pictures, severe damage, extensive damage, and intraoperative image. So this is what we did. So we did we reduced the dislocation and we did the fixation from L5 to L1 to 5. This is some intraoperative video, a fast-forwarded video. So in the interest of time, I'll skip this. Severe damage to the right side with the shattered nerve roots on the right side. 70% of the left side was preserved. So there was no dura. Dura was completely disrupted. So you can see the damaged nerve, damaged thecal sac. And I had to reconstruct the dura. And extensive decompression was done. Lot of hematoma was there. And the reconstruction of the dura was done. And this is the post-operative images. So the reduction was, the complete reduction was done with a good alignment. And this is the post-op CT. And this is the post-op wound. And this is him after 3 weeks. So his power, lower limb power was 5 out of 5, but right lower limb power was around 1 out of 5. But I'm sure he'll be able to, with rehabilitation, he should be able to walk with his productive limb and with the crutches. So that was a remarkable improvement for a case like that. So these are a few scenarios that I wanted to share with you all when working under difficult circumstances. As I said earlier, it's not all about the sophisticated techniques. It could be just adhering to the basic principles, basic microsurgical principles, and adhering to your believing in your skills, in your knowledge, mainly the anatomical knowledge, and making the correct decision most of the time, and doing a skillful job. But remember, the main intention or the main objective is towards the best patient outcome and the patient safety. Patient safety first, and then your comfort and the rest of the principles. So this is all what I wanted to show you, Sean. So,
Thank you very much. Takashi?
Dr. Surat, hello. Thank you very much for your wonderful webinar. I was so happy to join.
Thank you. Thank you for
Thank
the
you.
wonderful lecture.
Thank you.
So yeah, so the under your circumstances, so very aggressive and very fine surgery, under those circumstances, you tried the best, you did the best. So I appreciate and respect your attitude to be as a neurosurgeon, and I was very stimulated. Thank you.
Thank you very much, Dr. Takashi. And thank you, Nargis, as well. So one of the cases, I hope you can remember we did together, that
Yes.
the frontal meningioma.
Yes, sir. I wanted to ask the question regarding sphenoid wing meningioma. You, in 2 cases, you didn't put bone back, right? So the brain was swelling, or
No, the brain was lax. But sometimes, depending on the circumstances, I was a bit reluctant to put the bone flap back because sometimes I expect post-operative edema, but actually in these 2 cases the bone was very lax. So
Okay.
the brain was lax. But considering, you know, the post-operative care, and
Yeah.
with some of the bad experiences I had during my stay in in teaching hospital Fatapura, sometimes I think twice before putting the bone flap back. But definitely, as you said, I would have put the bone flap back in both the cases. So I think it's better to put the bone flap back.
Okay.
But due to
And
some reason, yeah, I didn't replace the bone flap during these two cases.
okay, sir. But whenever you go for sphenoid meningioma, do you open cisterns widely? Like, do you proceed cisternostomy? Because with Ivcherian professor, we usually do like that. So before any tumor which is located, and whenever we go for anterolateral approach, we usually routinely open cisterns.
Yeah. Most of the skull-based surgeries, we do I would like to first do the Sylvian fissure dissection, and
Yes,
then I
sir.
straight away go to the optic carotid cistern and release CSF. So most of the time, because we do not perform these lumbar drains intraoperatively. So
Yes, sir.
if there is a VP shunt, I think it's easier. But if we don't have a VP shunt, I always perform this CSF release of the optical carotid cisterns and then go for the tumor resection. So that's very easier, uh, giving a lax brain most of the time. But sometimes, you know, in huge tumors, sometimes it's difficult to go for the, you know, I mean, cisternal opening before doing some of the debulking. But most of the times, yes, you can open the cisterns and go for the tumor debulking there.
Thank you, sir.
Very good. You know, I didn't realize, Sarath, we've been doing these for 5 years.
Yeah, of course, it's been 5 years now.
Well, that's great. You know,
Yeah.
we're trying to change, I'm trying to change the model of the webcast to make it more of getting sponsors from the medical device community
Yeah.
rather than going to societies, because as you know, and Takashi knows, probably Nargisa knows, is that societies don't have money. The neurosurgical societies, they just don't have money. So, however, obviously the medical companies do. The top 20 medical device companies all make money. These companies are making huge amounts of money, and we're glad they are. And we want to welcome them back into a digital format in which they find advertising useful to them. They obviously have to change to the world. It's not going to stay, the model of conferences, in-person conferences, the days are limited. There'll be a few, but not many. It'll be mostly online. And I'm glad to see that Nargiza is doing an excellent job with the Russian community. And I'd like her right now to go over the webcast coming up right now, basically. Can you go over that, Nargiza? Go over the people speaking and everything?
You want me to talk about my grand
Yes.
rounds, right? Upcoming.
Yeah, of course,
Yes,
of course.
21st of April, this Sunday, 12 p.m. Moscow time, 6 a.m. Miami time. We will have a skull-based session in Russian neurosurgery grand rounds. So we will be calling a few neurosurgeons from Russia, and Professor Kazari from Zimbabwe, and Professor James Liu from New Jersey. They will be talking about different skull-based lesions. So most welcome. And also, I would be glad if Dr. Surat and Dr. Takashi could join one day for webinars as a speakers. It's a great honor for me, because I never had before any neurosurgeons from Sri Lanka and Japan. So, sir, if you
Okay,
Of course.
good.
More
Let
than happy to
me
join.
let me just go over the webcast specifically, and
yes.
maybe you can speak about the speakers, Nargisa. Can you talk
Uh,
about the talks? Yeah.
Yes, we changed a little bit. So we will have Dr. Jamil Rizaev. He's one of the big neurosurgeons in Russia, and he's a director of neurosurgical center in Siberia. So he's considered as a skull-based neurosurgeon. So he will be talking about his case presentations. Also, we will have Dr. James Liu from New Jersey, Professor Kazadi, and we have changed. The young neurosurgeon will present next time. Instead of that, we will have one neurosurgeon from Italy, and also co-moderator and moderator, Dr. Ganau from Oxford University. Me will be as a host. So
Yeah, very good. And as you can see at the bottom, we have a banner. It's like a commercial. It's like a commercial. And what we do, Sarath, is that we have the webcast like we have now, but then we say to the panel, okay, that's a didactic portion. We're now going to present a product by our sponsor so that they will pay for the conferences that you do, Sarath. They'll sponsor them, just like they sponsor conferences now. They sponsor conferences. They usually pay, a vendor will pay $50,000 to set up a booth at a conference. And that's expensive. I mean, and so therefore, these medical device companies should have money to invest in a better form of advertising, because this advertising is going to be much better than just showing a banner. It's going to show a link that they can put onto their banner that'll bring them to videos of the product, the AR reps of the product. Virtual reality is going to take a bigger part in advertising, showing the product from different angles and how you use it and stuff like that. But it's going to be a dynamic field, and Zoom is going to change advertising. I'm betting on it. What do you think, Nargiza? Is that a good bet?
yes, it is.
Good. We'll try it, because I feel terrible. I've been bothering people for years about paying for their conferences, but they can't afford it. They just don't have funds.
Yeah,
So we're trying a different approach.
that's
but
true. Yeah.
Okay,
Yeah.
very good.
I'll try my best next time, John. So you have been doing a wonderful job through the neurosurgical fraternity, even
Yeah,
though a
I enjoy it.
non-neurosurgeon. Yeah,
I enjoy it.
we were
Okay,
thankful for that.
okay.